Hi, I'm Greg Stanley. I'm here with Wes Warren. Today we have a topic we want to discuss that unfortunately really has been forced upon us. The topic of associate improvement or associate conversion. So many doctors find themselves now with staff uh, that they're looking at in interviews that they wouldn't have hired 2 years ago, but today they're feeling like they really don't have a choice. Some of them are associates. Some of them have associates, and maybe they're not exactly clear on how good a job they're doing, but they're not really sure what their options are. So let's start, if we could, Wes, talking about whether or not associate is filling the bill, whether they're measuring up. And then we'll talk about what to do about it.
Yeah, so we had the case today where we were talking with a doctor who that was the kind of the problem is assessing are they doing good? Are they doing bad? What's good, what's bad? And our threshold, our bottom number, meaning you're probably maybe even losing some money, but not a lot, is 3,000 a day. If they can't produce above that number or near that number, you're in the break even to losing some money zone, depending on the practice. That's just barely covering the cost, and there's probably some slippage there in the end.
Wes, I was in on that call with you that you're talking about, and we were listening to a doctor talk about associates that had been in the office for 5 years and still turning in numbers that weren't by any means fulfilling what you're talking about as a benchmark. Now, I personally kind of think what was going on was he was producing very, very well. And so he didn't really think much about it. He just thought of them as being there and didn't insist that they step up and shine.
Yeah, well, that's exactly. I think you're absolutely right. Is that he was carrying the practice, and the minute he didn't want to or took some time off, it reflected in the net big time. The associates just really couldn't come up to speed. They're hitting numbers that we expect new associates straight out of school to produce in 90 days.
What's got to be difficult too is an associate who has been there for 5 years or 3 years or whatever, uh, almost shocked and asking to themselves, why now? Why do I have to do all this now? Well, you really should have done it all along. I think what you were talking about too this morning was that it's not even profitable. It just happens and you've quit thinking about it, but it's not profitable.
At 3,000 a day, it's probably close. It depends on the practice. It could be under profitability. I mean, you're right at the borderline there. You kind of got to get to 4,000 a day before there's even any hint of anything for an owner there.
Is there anything that doctors tend to forget about when counting the cost of an associate that could show clearly to anybody listening that 3,000 just doesn't measure up?
Well, obviously almost a third. If you count 1,000 goes straight to the doctor. And then you got 2,000 left over to pay the bills and everything that goes with it. Team members, hygiene, front desk billing, all that stuff, and marketing. And believe it or not, this whole idea, and I think we talked about this last week too, is this whole idea that two can live cheaper than one. Doesn't really work. When we run the numbers out and we track obviously the overhead of offices pre-associate and then post-associate, the overhead runs right alongside the associate. So it climbs right with their production at the same rate that you're used to. So yeah, it's thin, and if they're not producing right around 4,000 a day, you're losing money probably. As a good likelihood.
6 would be better.
6 is our optimal. That's where we want to get them to. That's where you're making a healthy amount. And so, yeah, the answer is 3,000 a day. That's what we expect them to do in 90 days.
Right.
And anything short of that, you're questioning whether they should be there or not.
Okay, Wes, let's get into the hard, difficult areas of improving this. I have seen this in practices. I'm thinking of a practice in California where the doctor he was producing 70,000 a month in a practice. He actually predated the owner of the practice. He'd been there so long as an associate. So he'd been there like 20 years producing 70,000 a month. And we went to work on that situation and he got to 125 and he thought it was great. He wasn't feeling like he was being driven or overworked. Let's talk about what we can do, what doctors can do to help their associates be all they can be.
First thing is to do is assess where the problem is. Is it me or is it you? Are we providing enough patient flow for you to hit that number or not? And there's a good chance most offices are. Most offices are actually over generous with patient flow to the point where the owner suffers, where the associates are picking up twice as many new patients and doing 20 or 30% more hygiene checks. That's normal. And it really shouldn't be that way. So first assessing, are we giving them enough patient flow to hit this number? And that can vary a little bit, but certainly you got to have 8 to 10 hygiene checks a day to be able to hit these kind of numbers. Anything short of that, and it's you haven't provided for them. It's not them.
Okay, so we're going to do a comparison between the associate and the owner based on their encounters with new patients. So let's rule out,
and hygiene checks. Yeah.
Let's rule out from the owner dealing with people that have been directly referred to him, because that's kind of the lay down sale of dentistry. So maybe comparing.
There's certainly an advantage as being an owner, so you're going to have 20-25% distorted numbers when you look at your numbers, your case acceptance. You're going to be do better than any associate. You should at least do better than any associate in there, but it should be within a margin of error. It should not be outside of that 20-25% difference.
So let's undistort them for a minute. Let's take out the referral patients, and maybe if we can, people that have no trace to other patients in the practice, compare those with the owner and the associate and try to get a picture. And you're saying we should be within 75%.
Well, if you don't do that stuff, you should be the associate, he or she should be within 75% of any metric, maybe even 80% of any metric that the owner has. Now you strip it out like you're talking about, and you're going to see it get closer.
Okay, we've done that. We've boiled this down. What's our next step?
So once you've kind of decided that, hey, we're giving enough patients, they're seeing plenty to hit that kind of number. Then you look at a couple different things. So one is, how much dentistry are they finding in general? So how much is being diagnosed per patient compared to the owner in the practice? Is it similar? Are they finding the dentistry? Okay. Then the next thing we look at is, what's phase one look like? On an average, how much is being presented as phase one? And that also should be similar to the practice norms and what the owner does. It might not be perfect, but it needs to be close. And that tells us how much dentistry the owner's watching versus the associate. Those numbers shouldn't be drastically different. A lot of times we'll see those numbers be drastically different. And that's a matter of the associates might not be aggressive enough or might be too aggressive. So we'll see the opposite. If you're too aggressive, you get zeros. You get people saying no, 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 and all of a sudden you have a case acceptance problem because you're too aggressive. And then we see people that aren't aggressive enough with how they treatment plan. Usually, all you've got to do is point this out and show the comparison and talk to the doctor about how you like to diagnose and try to calibrate the diagnosis, how he diagnoses or she diagnoses. We have a calibration exercise we put our doctors through that Dr. Peterson made for us, is a consultant for us, who did work as on the regional examining board. And they get 8-10 doctors in a room, and they have to quickly figure out what and calibrate what's a crown, what's filling, what's this, what's that. So he put that together for us. But that's what you have to go through.
Okay, so there's what we see and what we don't see. We nail it down, make sure that we're clear on that. Something I've heard you talk about in the past is an associate's incredible ability to present the exact same treatment plan as the owner without the self-confidence it takes to carry it across.
So once all that checks out and everything looks normal, within normal ranges, it's not wildly different, then we go into the elements of case presentation and what the associate could improve on. But also we go into support staff. So we look at the hygienist assistants, and we look at the treatment coordinators and make sure that there's a system in the practice. A lot of practices that there's no system, that just, they don't talk about anything. It's just hand it to the doctor and the doctor just takes care of everything. And they go to the front desk knowing what to do, and it's just all wrapped up. With associates, we're having to do a lot more heavy lifting with pre-assessing the dentistry before the doctor walks in the room. And then of course with treatment coordinators working with them. So obviously some kind of system, is there a system in place before and after the doctor walks in the room? And is there a lot of training and support for that? The next thing we look at is the doctor themselves, what they say and how they say it. I'll tell you the number one thing that we see as a problem with associates is what you're talking about, the confidence, the tone in their voice, the ums, and they just don't sound very confident in how they present. They'll be confusing. They'll talk about a lot of different things. They won't nail down a clear and concise treatment plan. And if they do, it's all filled with uncertainty and ums and and it just doesn't work in dentistry. You will see drastic case acceptance differences when you start throwing in yeah, I would maybe do this. When you start to come across as very unsure, the difference just shears off. I mean, we're talking, you can see a 60 to 70% drop off in the dollar amounts accepted by patients. So you take one doctor, same patient flow, does 100,000. You put another doctor in, same patient flow, will do 30,000, just because of those confidence and how they present. That's one aspect of case acceptance.
Okay, we've got to get that nailed down, and I'll tell you why. We got to get them with a sense of how they present. They're not confident or whatever, and they're working on it until they really get good, because they have to. It's like a pianist. They play with two hands, and it's not the same thing. Piano is two different things going on.
Right.
In a doctor's encounter with a patient, we've got the confidence, the simplicity, all of that. And then they've got to be able to read the patient while all this is going on. Is the patient giving the vibe of, yeah, I need to do this, or, that's too much? What's the patient saying with their face and their body language? And so you can do this, but it's something you have to accept. The idea that you hired a doctor, they have a degree, they have a license, you just turn them loose with an operatory and an assistant, that's going to end badly. Now, as it happens today, we're probably going to have to take somebody farther down that scale who's probably not as good at a lot of things and bring them up to speed. So we got to understand, part of having an associate now means more hands-on development than it did before.
Absolutely. I'm seeing it all across the country, all of our new doctors coming in as but the younger ones, it's just a different than what I'm used to, you know, even 10 years ago, 5 years ago, even. It's they need a lot more hand holding to come up to speed to really does to really deliver you know, which would be normally considered just doing average. We're having to do a lot to get them there.
Can I add one more thing? I would shorten the cycle of evaluation, whereas, you know, some people were looking at the associate every 6 months or something, like, you know, I don't think that's worked so good. He's been here 5 years and he probably should have been gone after 3 months, you know. I would shorten the cycle to weekly. One patient doesn't tell you anything, but in a week's time, you know, 5 or 6 new patients, enough treatment, enough hygiene checks, you get a feeling of where this person's at. Are they reading the patients right? Are they confident in presentation? Are they showing the same amount of dentistry you show? So let's shorten that cycle.
It has to be evaluated weekly. It has to be, the numbers have to be shown to them weekly. You have to put pressure on them. You know, without pressure, people obviously just don't rise to any occasion. Let's just be real.
Funny you say that. Some of the toughest people I've ever seen to upgrade, if you will, as associates, have been working in public clinics and so forth, doing massive amounts of dentistry poorly.
With no resistance either, though.
No resistance,
Right.
and very limited in what they're able to accomplish. So, but know this is a new era. It's a new market. If you can't take on this challenge we're talking about, it's going to be hard to afford to have an associate. They're going to just sit there and underperform.
Yeah, I had a doctor who brought on an associate. That was maybe a year ago, and we're working with them, you know, the first couple 2 or 3 weeks, trying to get these numbers up. It wasn't going good, you know, and just one day he didn't show up, and we're like, what happened, you know? And he rethought his life and realized he didn't want to be a dentist anymore.
Well,
he literally went to school to become a dentist, spent 8 years, got in, and is out of the industry completely. We were putting a very kind pressure on them, and not, you can't really, you know, put a lot of pressure on people, but you know, they got to come up to some kind of level. Yep, just quit. We got another doctor in there, you know, and we had to work with him a little bit, but he came up to speed and is now doing 5,000 a day. So
that's the process. In other words, you are sometimes on the wrong trail. You're out looking to recruit you're trying to recruit yourself, and that's just not on the market. You have to get somebody farther down the scale and bring them up to speed. Wes, thanks for sharing those things. Anything else you'd add?
No, I think that constant oversight, even if you've got an associate that's been there, where you review these numbers and you work with them on their presentation and everything for a good 90 days to get them up to speed to decide if they're going to make it or not. We've
pretty much shared what we do when we're involved in this, so you can do it yourself, but you can always call on us. You can call us at any time. You get on click the link and make an appointment and discuss with us the associate challenge or the practice challenge you're facing. Thanks for listening, everyone.
Thanks for listening.